Hello and welcome to our session today. I'm Dr. Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University, and I'm really delighted to welcome you to the session today. We're going to be talking today about gender identity and sexual orientation beyond the world of pink and blue in healthcare and graduate education. And it really is an honour for me to welcome our other panelists here today, Trish Voss and Ali Williams. Dr. Trish McQuillan Voss, DNP, CNM, CNE, is an Associate Professor of Nursing at Frontier Nursing University. She's the Course Coordinator for Statistics and the Regional Clinical Faculty for Oregon, Montana, Utah, and Nevada. Dr. Voss presents nationally on LGBTQ access to care issues and has a particular focus on the healthcare needs of lesbians and transgender men. Alexandra Williams is an instructional designer at Frontier Nursing University and has worked in higher education environments for 10 years. Ali holds a bachelor's degree in liberal studies with concentrations in applied linguistics and behavioral neuroscience. Her master's degree in education was in educational technology and focused on the integration of new technology into classroom environments and curriculum design. Her research focus during graduate school was on the applications of gaming in education. Her research interests include web accessibility, media and health literacy, and using simulation to address healthcare disparities. And just a little bit about me. I've been a midwife. I've been very lucky to have assisted at over 2,000 births with families all over the world. I trained as a nurse and midwife in Scotland, and I've lived and worked in Musami, Zimbabwe, and Wellington, New Zealand, before I came to the United States in 1996 to continue my midwifery journey. I'm very passionate about increasing the quality of care, particularly in rural and underserved populations, including for gender non-conforming persons. So welcome to our talk today, and I hope you find it quite lively and stimulating. So our objectives today are, we're going to identify the origins of sex and gender assignment at birth. We're going to be examining the curriculum of graduate education in this area. We're going to discuss the impact of gender and sexual orientation stereotyping on health behaviours of gender non-conforming and sexual minority individuals, and then discuss the impact of gender and sexual orientation stereotyping on access to care of gender non-conforming and sexual minority individuals. According to the World Health Organization in 2017, gender is a word that describes characteristics of people that are largely socially created, and I'm going to go on and talk about that a bit more in a minute. Sexual assignment encompasses those that are biologically determined, and it's very important with these terms that we use the correct terms when we're not interchangeably using gender and sexual assignment, because we're going to talk about that, particularly in healthcare, the importance of sexual assignment and the difference of that to what your gender identity is. When we think about the United States, for example, and gender and sex assignment, as a midwife, and I'm sure the folks on the panel here that are midwives can think about, you know, it's always, it's a boy, it's a girl. We now even have, and I've been to them myself, they're called, can't stand it, gender reveal parties. So it's a really big thing now that we want to know, is the baby a girl, is the baby a boy, what colours are associated with this kind of thing. And I have to be honest, a little story here. I went to my local Publix to get a card for a baby shower. I couldn't even get one that was gender neutral, so there was only one. So if you don't know your gender, you decide not to find out, you can't buy a card at the store now. There's also, we think about cultures with more than two genders. For example, if we think about Samoan culture, they have a third gender, fa'afine. So that's a very interesting cultural aspect to gender there. There's also socially inbuilt expectations for different genders, and that's really changing over time. As I get older, we see a lot more lessening of social expectations, whether this is a man's role or a woman's role in society. One of the important aspects, though, of the medical aspects of sex assignment is that, for example, we know that there are specific inherited diseases. For example, I just noted here about Duchenne muscular dystrophy. So diseases that are inherited in an X-linked recessive pattern mostly affect persons that are born male, because a second X chromosome usually protects females. So that is an important thing to think about if you're assigning sex at birth. If the person is born male, they may be more prone to X-linked recessive diseases. So when we think about sex and gender, we can think about perhaps male, female, and intersex, and genders of masculine, feminine, transgender, and more. So sex refers to biological differences, the chromosomes, hormonal profiles, and internal and external sex organs. However, the gender is the characteristics that a society or culture or person can delineate for themselves. So that could be masculine, feminine, or non-conforming. Or in fact, obviously transgender fits in here as well. Sexual orientation is an enduring pattern of romantic or sexual attraction to persons of the opposite sex or gender, the same sex or gender, or to both sexes or more than one gender. So what do all these letters mean? And we seem to get more and more. We want to promote inclusion with our presentation today. So what do we really mean when we say the acronym LGBTQI, P, 2S, A, and A? So I'm going to talk about that now. So the L typically refers to a lesbian, which is a woman that's typically sexually attracted to other women. Gay is generally a term used for homosexual males. However, many women use that also. Bisexual means that you're attracted to both genders. Transgender is a person identifying as a gender that's different from your one that was identified at birth. The word queer is quite controversial. Some people will, especially younger people, may identify as queer or part of the queer community. They feel that it's an empowering word that's been taken back from bullies. Questioning refers to people who are unsure about their gender identity or sexuality. Intersex are persons that are born with various chromosomal differences, or may in fact have two sets of genitalia. And this was formerly known as the word hermaphrodite, which is now considered very offensive. Pansexual means attracted to all gender identities. Two-spirit is a tradition in many First Nation cultures that considers sexual minorities to have both male and female spirits. Asexual are people who are not sexually attracted to anyone and do not identify with any orientation. And then we also think about including the word allies in here. You'll notice particularly some members of the LGBTQ community do not include the A for allies, but these are supportive members of the community. They support, and they're typically straight people that are supportive of the LGBTQ community. So just going on to talk about assignment at birth. So sex assignment is the determination of an infant's sex at birth. In the majority of births, especially the ones I've been involved in, and it's been many, the healthcare provider or relative or the actual person that's giving birth themselves will look at the genitalia of the baby and announce what the gender of the baby is. Actually, the sex assignment, sorry. So assignment may also be done prior to the birth, as I said, through prenatal sex determination. This word assignment suggests a decision, and I would like to say that this is an observation or a recognition, because we do know that there is cultures, particularly in Northern Europe now, where their tendency is towards not identifying a sex at the birth, but bringing the person up as a neutral gender. So we're not actually saying that the baby's a boy or a girl. So in the majority of cases, though, we know that the gender of rearing of the child matches the gender identity. So the act of the assignment can carry the implicit expectation that future gender identity will develop in alignment with physical anatomy, assignment, and rearing. But of course, that can be quite problematic when your sex assignment at birth does not align with your future gender identity. So people who have gender identity or gender expression that differs from that associated with their assigned sex may identify themselves as transgender or gender non-conforming. The best explanation I could discover for the reason that society has become so involved and interested in this is that a report from 1811 in the Netherlands stated that it was really important to assign the sex at birth so that they would have more information about the population. They'd have gender-specific rights and responsibilities, such as military conscription. So that's really how we came to this place.
Hello, I'm Allie, and I'm going to talk to you a little bit about the curricular issues that we have surrounding the teaching of LGBTQ content in graduate education. So, as we start out, I just want to make a little bit of a note that I generally refer to the LGBTQ community as the queer community because I identify as queer, but I understand that some people just aren't feeling that kind of terminology. So I support the right of others to identify as they feel appropriate. But in this presentation, you'll probably hear me mix the two up, and you might see an acronym where I say something different. So that being said, there are three primary issues that I'm going to touch on today when it comes to curriculum and queer content. So in short, they're the fact that little time is devoted to LGBTQ-focused health content in most graduate education programs. Content, when available, often treats the queer community as a monolith. And the third part is that content is often taught in a way that reinforces stereotypes. So when we look from curriculum at a general standpoint and the amount of time that's focused on this kind of content, few studies really exist that quantify the amount of time assigned to queer content in health professions education. When I say health professions education, I mean primarily advanced practice education, so med ed, APRNs, PAs, PTs, etc. Those people who are expected to have more of a clinician role, decision-making part of a patient encounter. So not pre-licensure kind of stuff, just the more advanced graduate education. In 2011, a comprehensive study was done and published from 2009 to 2011 of medical curriculum in the US, of med schools. They had attempted to survey the curriculum deans of all MD and DO programs in the US and Canada. I think there's about 140 of them altogether. And they got about an 85% return rate, which is actually really good. But they found out that the average student only received about 5 hours of LGBT-focused curriculum across the board, and that was through all 4 years of schooling, didactic and clinical. And most of those focused on singular issue items. They really lacked an intersectionality kind of issue. That was also the median, so the 5 hours, and not 5 credit hours, but 5 hours. That was the median. I think it went up as high, if memory serves, of 16 hours in some places. But there was a considerable number of schools that offered 0 in the curriculum. And this also didn't include like student-initiated content. So if you had a student group, like a pride group that decided to put on a panel, that wasn't included. This was only curricular issues. So to my knowledge, no one has yet undertaken the same kind of scope of study when addressing other advanced practice programs in the US. But from what we've seen in smaller studies, there really isn't a lot to challenge that finding in and of itself. There's not a lot of evidence to support any kind of different conclusion. The good news, though, is that with the increase of programs that focus on diversity and inclusion and the increase in focus on things like cultural humility and cultural competence, there's, the culture is being built that will allow this to be addressed in a much better manner moving forward. So the second problem is that content often treats the LGBTQ community as a monolith. So the queer community is a wide-ranging, diverse group of people. Unfortunately, from a curricular standpoint, from a content standpoint, they're often treated as if they are one distinct kind of cohesive block, one big acronym. And this makes it really difficult to understand the wide range of health issues and barriers to care and lived experiences of the entire community and its various members. So for example, the experiences of LGBT elders are often overlooked by curriculum, but they're distinctly different from the experiences of queer youth. So additionally, you'd have very different barriers of care experienced by a transgender woman than you would for, say, a bisexual woman. And the third main primary problem is that content is often taught in a way that reinforces stereotypes. And that's not usually intended, but it happens nonetheless. And there's two primary pathways for this to happen. And the first is assumed heteronormativity. So it's generally very subtle, but say you go into a simulation experience and somebody says, well, my spouse did this, and they're female. They say, oh, well, how was your husband doing? What did he do? Well, that assumption that the spouse is male happens quite a bit. The same things happens if you see pediatric encounters where they say, well, mom's here, where's dad? You know, that assumption that mom and dad are the only two options. And it's not intentional and it's very subtle, but what it does, that assumption challenges or has a lack of challenge and discussion that makes it normative to exclude queer populations. So it reinforces that kind of stereotypical or heteronormative understanding that queer populations are marginal and that they are outside the scope of normative practice. And it often does so without realizing or intending to, but it's one of those reinforced implied relationship kind of things. So if you don't say it and you don't recognize it, you have a tendency to believe it's there. So for people who are straight, a lot of times that might seem like a new way of thinking about it. And it might seem like something that you hadn't realized or like an over-the-top kind of focus on the way that we do things. But I can tell you that your queer students and your queer patients notice. And they notice pretty quickly and pretty abruptly. The second problem is that we often tie content to specific populations. So a really good example of this is that when we talk about HIV, we usually talk about gay men and we also talk about promiscuity. And in some content and in some curriculum, that may be the only time you talk about gay men is when you talk about HIV. Now, it's not to say that HIV isn't a problem in the gay and bisexual male community, because it is. But when it's the only time that gay men are discussed, it kind of creates a link between the two that's not necessarily a realistic link or an entire link, I guess is a better way of putting it. It's not showing you the whole story. It also supports those kinds of stereotyping, those promiscuity stereotypes. There's different stereotypes. At the same time, when we talk about transgender, and maybe we only talk about it with mental health, same kind of thing. It enforces some links there. And it also ignores the needs of other populations. So for example, the CDC states that in 2015, almost 20% of the new diagnosed cases of HIV were women. If we're really creating this link that HIV is gay men, then you're ignoring a huge subset of the population that we need to be thinking about as far as a provider-patient role. So when you do that and you exclude that kind of group, or you just don't think about it, because you're not intentionally excluding other people, but you're creating a subtle link there in your head, what happens is that it affects the way you think about testing and treatments and preventatives and how you offer them to different groups rather than to the public at large. And PrEP's a good example of this. PrEP is almost entirely marketed to gay and bisexual men, but there's an entire subset of people who aren't gay and bisexual men who could greatly benefit from knowing about or having access to PrEP. So unfortunately, this kind of marketing and this kind of thinking forces this work to be done by grassroots organizations, private healthcare organizations, and public health works, rather than be included as part of that primary care program and of course sex ed, which could be an entirely separate presentation in and of itself. So what we want to do with content is we want to create content that's inclusive, that's for sure. But we also want to provide opportunities to deconstruct myths, to challenge bias and stereotypes, and to increase that overall awareness that providers have so that they have the tools to treat all of their patients comprehensively. So here at Frontier, we have, there's a lot of positives when it comes to addressing LGBTQ issues in the curriculum, specifically gender nonconforming kinds of topics. I have seen examples of lots of places where students and faculty have had really clear, meaningful discussions in courses. Topics such as pronoun use are addressed in clear and understandable ways in many places in the curriculum. And I've noticed that a lot of the textbooks and readings that I've seen as I've gone through different courses and looked at their curricular aspects are up to date and pretty clear and inclusive, which 10 years ago would not have been the case at all. So it's great to see this kind of thing being rolled into the courses and used by students. However, there are always ways that we can improve. So we're always striving to improve our curriculum. That's a continual iterative initiative of good education. You always strive to make things better. And we can do that by providing content outside of this narrow scope, integrating more content into other courses where it's relevant and helpful, and developing opportunities for students to apply that content in action. So such as interactive case studies, panel discussions through simulation, things like that. And those are just a few ways that we can improve what we already have and what we're offering to students. So as we look to the future and we look to what we want to increase and how we want to reduce disparity, because part of reducing disparity, of course, is making sure that our students are well educated before they go out and start working with their patients. We look at a couple of different things, a couple of different points that we look to delineate. So the first one is, where is queer content available? We want to know, is it available in all the tracks? Are all students getting exposure to relevant material? Or do we have an imbalance where one track gets something and one track isn't getting anything at all? So we look at that and try to make sure that what we're offering students is balanced. We also want to look at the quality of the content. Are we teaching in stereotypes or in two dimensions? Are we going behind the basic or beyond the basics and integrating intersectional topics? Is what we're doing patient-centered, or is it more monolithic? We also have to address whether or not we're sourcing things from queer sources. So are we using organizations such as the Fenway Institute, which is well known in the LGBTQ community and healthcare community, or and are we speaking to that importance of including and elevating queer voices in queer programming? We also want to look at how it's being applied in the curriculum. So how can we better improve opportunities to apply this content? And that includes asking how we can encourage some open discussion in courses where students can speak without judgment and challenge their own bias. It's important to have an opportunity to look and act and to look at the bias that we all hold, as well as receive actionable feedback and support rather than criticism. And then the last thing that we always want to look at is, does it meet learning outcomes? Because that's why we're here, right? We're here to learn and we want to help our students learn. So we have to look at the content and ask, is the content teaching what it is that we really want it to teach? Is it better preparing our students to serve this population? And do our students feel confident and well prepared at its conclusion? Because in the end, that's really what we're here for. That's our goal, is to make sure that students become the competent and the competent clinicians that we know that they can be.
Okay, so hi, I'm Trish, and I identify as a bisexual woman, and my pronouns are she, her, and hers. And I'm going to talk a little bit about the practice side of this in relation to curriculum. And as I earlier mentioned, lesbians and transgender men are more of a focus of my area. And so and as a midwife, pregnancy, of course, interests me too. So I'm going to touch a little bit on that. So first, as we've already learned, there is kind of a lack of our curriculum in addressing the needs for LGBTQ persons. So if providers are to learn about this, they're not learning in their education program, how can they learn about this now? So there are a lot of resources for providers to learn about how to care for LGBTQ persons. And as Ali mentioned earlier, the Fenway Institute is one of the well-known resources that can be used, and they provide a lot of continuing education. But because there's the lack of content right now, we're trying to hopefully address that and increase that content and preparation for our current students. And in the FNU curriculum, as was already mentioned, we have some required readings and case studies, but it really isn't a curricular thread. And I know that there are people listening to this presentation who are not FNU grads, and so I wonder if you can reflect on your program and what kind of preparation that you had in caring for LGBTQ population. When I was at the National Organization of Nurse Practitioner Faculty meeting in 2016 presenting on this, we had a meeting during that discussion, and then later on at one of the special interest group meetings, we took a show of hands from the educators on which programs do actually have a dedicated thread to address issues for the queer community. And maybe one or two hands were raised. And I know that's an informal poll, but still it does give you an idea that it is definitely an area where we are lacking in preparation. So Many LGBTQ clients are very uncomfortable seeking primary care because they know that there's some lack of understanding from healthcare providers, and they are not necessarily entering a practice where they feel welcome. So the question is, for those of you in practice, how many LGBTQ patients are in your practice? And how do you know? And what, if anything, have you done to make your practice safe and welcoming for the queer community? So going back just real quick on this, some people think, well, I've got lesbians because they identify as lesbian, but what if they haven't actually done that? How do you know that you have lesbians in your practice? And how do you know if you have anybody else in the LGBTQ community in your practice? Unless they're identifying and feel comfortable letting you know that, you don't really know for sure. So I worked with a couple doctoral students who were developing toolkits to help their providers in their practice become more welcoming and knowledgeable about caring for lesbians and transgender men. And one of the things that they talked about there was, first of all, the terminology, and Jane talked about that earlier, as well as Allie, that knowing what the terminology is and that whole alphabet soup, that's essential, because it's not just one group. It's the LGBTQ community, the queer community isn't just this one block of people. It's a huge mix of people with different needs and different requirements for their health care. And there's different disparities between the groups within the LGBTQ community, different healthcare disparities. So provider training and knowledge can come from the continuing education, just like seminars like these or more advanced seminars. But really, one of the things you need to do is make sure that you're creating that welcoming practice, and so that you can address their healthcare needs and they can feel good about coming to you and know that there are places that they can come for their care and they're not going to be judged, and that they will get the care that they need. And then for transgender individuals, where can they get their transition care? Because nurse midwives and nurse practitioners are really, that's within our scope of practice to provide this care, the hormonal care for transitioning, in conjunction with consultation with other healthcare providers. Fertility issues need to be addressed, and then particularly trans men in pregnancy and lesbians in pregnancy. So going on, creating a welcoming practice. As a regional clinical faculty, I have the privilege and opportunity to visit a lot of different practices around different states. And I've talked with different providers at those practices, and I ask them if they have, if they have lesbians in their practice, or if they have, transgender men in their practice. And, some will say, yes, they do. And some say, well, they're not aware of that, or they haven't really given that much thought. But even things I've noticed in the different practices is the physical environment of the practice isn't necessarily conducive to a person coming in who's gender non-conforming. If it all looks like men and women having babies and not two women or two men having babies, if the decor of the waiting room is not something that is supportive of the community that they're identifying with, if it makes them look different or in some ways makes them stand out, that is really not a supportive environment for them. And then you have the intake forms and patient education materials and all of that. If it's not something that is, if it's heteroconformative, which is what the majority of practices have, unless you make the change yourself, it's not going to be something that you're going to actually collect the data that you need to know if you have the, members of the LGBTQ community in your practice. So then you also need to do staff training. You train them to ask for the pronouns and names that your clients will have, their preference for their pronouns and their names, and be careful of being heteronormative, as was mentioned earlier, that just because you have somebody saying they have a partner, that might be a male or female partner, but isn't necessarily the mommy and the daddy. So also be aware of personal biases. And that's really one of the harder ones, because we all know that personal biases exist, and that's not just with the LGBTQ community. It's something as healthcare providers that we need to work on for all of our clients. And then being aware of the subtle misgendering, and that's referring to people assuming that they are one gender when they actually identify with another gender. So for trans clients, and actually with lesbians, but particularly with trans care clients, the healthcare needs that they have people might feel uncomfortable with them. So just ask what terms the clients use for their anatomy. When you're doing exams on a transgender man, ask if they prefer chest or versus breast exams. They will still need to have cervical cancer screenings and vaginal exams, and in some cases for the male to female transition, they'll need prostate exams. You are able to do the hormonal care needs for trans clients. This is something, again, like I said, is in the scope of practice for nurse midwives and nurse practitioners. So the care will depend on the age and the pubertal status of the client. If they're not yet in puberty, the birth hormones can be blocked indefinitely. But if they're already through puberty and at age 16, usually, they begin those gender affirming hormones. The male to female will need an androgen blocker and estrogen, and the female to male will need testosterone. And you need to talk about the expected side effects of those with their affirmed gender. You also need to know that just because they're taking these hormonal treatments, they do not protect against birth. So they do need to have contraceptive care. So, and don't assume that just because you have lesbian and trans men that they don't need that contraception, whether they're transitioning hormonally or not. So considerations for the hormonal treatment for trans clients. For male to female, for their further sexuality and fertility, they may need to consider cryobanking, and they need to know that they're going to have decreased libido and erectile dysfunction and ejaculation with estrogen therapy. They need to be aware of that. And if with a female to male transition with testosterone therapy, they will have increased libido and decreased fertility. But there, again, no contraceptive benefits to this. So talking and preparing for trans men in pregnancy, this is generally a very deliberate decision. It's not something that typically happens by accident. And even within the partners, there can still be loneliness and isolation between one partner desiring pregnancy and the other partner being supportive, but the outside world is not necessarily supportive, as you can tell by all of the hoopla we had when we had our first pregnant man this was up in Oregon. And that can be very isolating and can lead to loneliness and isolation and depression. So it also can have effects on their gender dysphoria, their overall feeling of dissatisfaction with their assigned gender. And there's different ways then to engage with the outside world. Hiding and passing and telling. Now, if they're pregnant, it's going to be difficult to hide that eventually, but it's possible to do that. But if they don't feel comfortable showing their pregnancy, then they will do what they can to hide that. So after you've started the hormonal therapy, you have amenorrhea within 6 months of testosterone initiation, but you can have the resumption of menses usually within 6 months, and often 3 months after discontinuing the testosterone. So for pregnancy, they can use the partner sperm or donor sperm. They can use their own eggs or donors, and there's alternatives to surrogacy if they are partnered with a natal male. Lesbians in pregnancy, they will need the same kind of preconceptual counseling as anybody else. And what they're, in this case, we also want to talk about donor insemination, and there are different things you need to talk about with them. Some of you may be old enough to remember the turkey baster babies of old. So now we need to know that there are a lot of different options for artificial insemination, and we have to know making choice between fresh and frozen semen and known versus anonymous donors. Fresh is more effective than frozen semen, and also there's different ways to do the insemination, intrauterine and endocervical, with intrauterine insemination being more effective than endocervical. But with frozen semen, and whether you use fresh or frozen semen, you do need to do the donor testing, and that is done according to the United States standards. And there's reasons for that, of course, for just transmission of diseases and problems in the past with the do-it-yourself-at-home type turkey baster babies is that semen was not tested, and infections and other issues can arise. Versus known and anonymous donors, do you know if you want the partner or the person who's provided the donor semen, is that person going to be part of the child's life or not? So there's a lot of other issues you need to talk about and counsel with your pregnant clients or those who are desiring pregnancy. And then you need to talk about the issues of ordering and storing the donor semen and the insemination process, like I said. and overall pregnancy care, and making, again, sure that your office is supportive and comfortable for your non-conforming family. So perinatal issues to consider, making sure that your clients have rapport with your provider and staff. Waiting rooms, again, if people are not comfortable being out in the waiting room with the conforming population, you might consider having private waiting rooms for them, or you might also consider having different times for your queer community clients coming in. And also you need to prepare the hospital or wherever they're going to give birth, and prepare that facility so that they're aware that you'll have different types of clients coming in labor, so that they're not treated inappropriately when they present at the labor unit. And then, of course, you'll have to have access for parenting resources for them. Any kind of provider referrals, you want to make sure that you're going to refer to people who are going to be supportive. And then plans for feeding. This is particularly for trans men, if they've had any kind of breast reduction surgery, or whether they are, even if they have not and they're using binders, what are their plans for feeding? Do they want to do chest or breastfeeding? And those are other issues to consider with them. So basically, it comes down to we have that scope of practice to care for the queer community and their individuals and families, and we need to have good provider knowledge. So if most of us did not get that in our graduate education programs, and so we need to take the initiative to get this extra knowledge and add this to our practice toolkit, and always create a safe, welcoming practice environment for everybody. Thank you.
So, in conclusion, we hope that you've enjoyed our presentation today, and our own gender identity, expression, and sexual orientation are essential concepts to our innermost perception of self. And this is really important. As a lesbian who has recently come out as gender non-conforming, I think it's really essential to think about how your own gender identity and expression and your orientation affects your perception of self. And as healthcare providers, we must all be attuned to our own selves so we can provide sensitive, culturally competent, and appropriate care to all our clients at every stage in their lives. So here's our resources, and thank you to Ali. She has developed a wonderful LibGuide with lots of resources there. So if you can copy and paste that and look into your browser and take a look at all the information that Ali has prepared for you there. And here are emails. We'll be happy to talk with any of you all if you have any questions about anything you've heard today. And we hope it was a useful and helpful and inclusive presentation, and you'll feel more comfortable in your gender identity, sexual orientation, and work within the university and in the healthcare setting. Thank you so much.